with that, I'll turn it right over to our pathology colleagues for pathology grand rounds.
Great. So I will let Dr. Patel actually introduce the Biopsy Conference series since he's taken over the organization of that from Dr. Najafian. So Anand, if you're there, please go ahead.
Yeah, thanks, Ram. So yeah, hi everyone. Welcome to our first kidney biopsy conference of the year. And especially we want to welcome the new fellows who we haven't gotten to work with as much yet. And we look forward to meeting you over the course of your fellowship. So, so here on the slide are the dates of our biopsy conferences. We'd like to introduce who we are. So there's six of us in renal pathology here. Four of us, Dr. Smith, Dr. Akalash, Dr. Najafian, and I are on active clinical service, and then Dr. Alpers and Dr. Nicosia are not on clinical service, but still very active in our community of renal pathologists. So you'll be hearing more from all of us at our conferences and as we discuss your biopsies over the course of the year. So yeah, thank you all for joining, and I'll let Ram continue with the first case.
Great. Thank you, Anand. So let's see, move it forward. Okay. So so the first case will be presented by Bilal and myself. And Kate, I don't know if you're able to hide the names of the annotators from the moderator level or whether attendees have to do it, or if you feel brave, you can, own your annotations. We'll have a couple in this particular talk.
I think I am not, Ram, if you want to try to do it before you continue
Oh,
on.
okay. I have to do that. Okay, let's see. Okay, I see. I got it. Okay. So I hit everyone's names, so you can be anonymous and fearless. Okay. So let's go ahead, and I'll hand it over to Bilal.
Hello, good morning, everyone, and welcome to our new fellows. I guess I've worked with half of you folks, and I think based on that experience, there is hope for the other half. So let's start. So my patient, he's, I think, 60-ish. He has hypertension for about 10 years, for which he's requiring losartan and amlodipine, almost adequate control, and then also has diabetes for the last 7 years, being treated with metformin and empagliflozin with what appears to be stable glycemic control, and some atorvastatin for his lipid problems. So back in 2019, he got diagnosed with this anaplastic large cell lymphoma, and over the next several years, required this antibody brentuximab-based regimens. So he would go into remission, then he would relapse, had about 4 relapses. Finally, they teed him up for hematopoietic stem cell transplant after bringing him into complete remission by December 2023. And at that time, there was no evidence of any lymphoma by his bone marrow biopsy. So he undergoes a hematopoietic stem cell transplant on January 17, 2024. This was a well-matched peripheral blood sample from his brother. He gets a myeloablative regimen with fludarabine, melphalan, and total body irradiation. And as goes with allogeneic stem cell transplants, he's put on immediately for immunosuppressive protocol for acute GVHD prophylaxis, pretty standard cyclosporine, MMF, except that they use this new drug, which I'll show you later. He just got 1 or 2 doses of, called belmisodal, which is so-called ROCK2, which is a kinase, intracellular kinase that blocks fibrotic pathways. So this was his acute GVHD prophylaxis. Next one. So his post-stem cell course was a bit complicated, like many of these folks have. He did develop some acute skin GVHD, rash over about 40% of his body, but was stage 2, did get better with topical steroids, and also had some CMV reactivation for which he received a course of Valic and cyclovir and improved. With regards to his immunosuppressive protocol, he got tapered off, I would say, about 7 months after his stem cell transplant of both MMF and cyclosporin, then required a small course of prednisone for what they thought might be a lung GVHD in September. So by December, which is almost about 12 months after his transplant, he started developing diffuse body edema, but anasarca-like presentation, 20-pound weight gain, difficulty urinating, increasing sclerotic changes over his arms and legs with reduced range of motion. He has a rise in his blood pressure. So the hematology service put him on like a mg per kg of prednisone, which came to about 105 milligrams per day. They start him on this, and then go ahead and get an echocardiogram, which Sarah can, interpret much better than me. Seemed like to be pretty okay with LVF of like 62%, with some diastolic dysfunction in this gentleman as well, because he had long-standing diabetes and hypertension, I assume. But otherwise, not really. This increased diffuse body edema likely did not appear to be coming from the heart. So he was sent to me in a month later. Next one. So I got some labs. So as you can see, his electrolytes are pretty unremarkable. He has wonderful kidney function. Other electrolytes are pretty okay. Nothing abnormal there. CBC is also pretty unremarkable. Of course, the first striking thing you see is his serum albumin being 1.9. And otherwise, again, unremarkable numbers based on uric acid, LDH, LFTs, and A1C. So his urinalysis was had massive proteinuria, and as you can see there, next. So I just gave a trend of his readings. By the time I'd seen him, he already had about 6 grams of albuminuria and had a remarkable drop in his serum albumin by the time he came to see me. So in other words, he was in full-blown nephrotic syndrome by the time he came to see me. Next one. So a quick view of his serologies. Nothing unremarkable on the serologies. They are right there in front of you. Next. A little concerning was his PET scan, which did show a little bit increase in size and metabolic activity of some cervical lymph nodes, which they thought could represent disease recurrence. Next one. So after I saw him, I, of course, started him on conservative management. I started him on torsemide. I added spironolactone, and after like a visit or so, increased the dose of his empagliflozin from 10 to 25, increased his dose of losartan. He continued torvastatin, and because his albumin was so low, I started him on apixaban for prophylaxis anticoagulation. So I told hematology team that the prednisone to me didn't seem like the thing that will do the trick. So they should start reducing it and tapering it, unless they were trying to treat some acute GVHD there. And by March or so, he did have an excisional biopsy of a lymph node, which thankfully showed that there actually was no recurrence of his lymphoma back. So he was in a good, stable state. So for his skin sclerotic changes that continued to get actually worse, and he did have some steroid refractory sclerotic skin chronic GVHD, and they started ruxolitinib, which is a JAK1 and 2 inhibitor, by April. And since his proteinuria kept getting worse, I treated him with rituximab 4 doses by March. Next. And I've shown you the labs. So he got, these all are post-rituximab levels. So over the next 4 months, yes, he had some improvement in his proteinuria from 7.5 grams down to 4.5 grams, but still very much rampant proteinuria. Albumin improved a bit. And the CD19 shows that that rituximab did what it needed to do, but still he continued to have significant proteinuria and hypoalbuminuria, and continued to have some volume overload, although there were improvements in there. His renal function thankfully remained stable, as did his hematologic parameters. So at this stage, I had another treatment in mind, and I discussed with the hematology team. They had concerns that because I wanted to increase the immunosuppression, and I had some differential in my head. And so, but they said, well, we're a little worried about over immunosuppressing him because he's already on ruxolitinib for GVHD. And then there was before that, there was concern whether he has recurrence of his lymphoma. So they wanted to kind of sort of see if we can go a bit slow. So that was the reason it took so much time for us to kind of keep following him conservatively. But finally, by July, as you can see, when things were not really improving as much as I would have liked. So I preferred that we should go ahead and kidney biopsy, and based on those, I would probably kind of sort of firmly say I need XYZ to do with this gentleman.
Okay, thank you, Bilal, for that presentation. So I have a blank slide here for people to kind of use that annotation tool if you'd like, and maybe use the text function and drop in some thoughts about what you think you have, this patient may have. Um, so just to kind of summarize, this patient had anaplastic large cell lymphoma, had basically hematopoietic stem cell transplant complicated by GVHD, and then started developing anasarca-like symptoms and heavy proteinuria, but with preserved kidney function about a year after the transplant. He was on multiple immunosuppressive therapies to try to tackle the GVHD. And then Bilal had tried rituximab to try to see if it could help his proteinuria. With some, definitely the B cells were depleted, but the proteinuria wasn't returning to normal. So any thoughts about what might be happening for this patient was causing the proteinuria? Or are people struggling with the text thing? Okay, well, we'll move on. So let's try the annotations here. And so while I describe this very beautiful biopsy, maybe you can put some annotations next to the biopsy core where you think the medulla is on this particular biopsy. So, so this was quite a tremendous biopsy. It was, a 2.1 centimeters long. So it's almost like a quarter, the diameter of a quarter. And so it consisted of both renal cortex and medulla. So it was an excellent sample. And overall, we had about 17 to 28 glomeruli across all the levels, of which only 1 to 3 were globally sclerosed. And so, so a good sign. It kind of matches the fact that the patient had good preserved renal function, that the parenchyma was actually in pretty good shape. So that's a good starting point. And so I see everyone's kind of pointing out the medulla here. Very nice. And so that is correct. And so you can see sometimes in these biopsies, they kind of dip in from the cortex into the medulla and sometimes back out into the cortex as well. So that was the case over here. And you can tell it's medulla even at this very low power because it's got a different texture in terms of the tubular profiles. We're also not seeing any of these glomeruli, these round structures here. We're also seeing perhaps some larger vessels, maybe arcuate-sized vessels, which are at the corticomedullary junction as well. So these are all clues that this is the medulla over here. And so everyone annotated that correctly. There's also a chime in about what the potential diagnosis might be. Minimal change was one of the suggestions. And Goyan also dropped in the chat that membranous nephropathy might be another consideration. So yes, both of these are in consideration for, kind of subacute onset of nephrotic syndrome. And Bilal, I think you said the anti-PLA2R was negative, correct?
Yes, it was negative.
Yeah, so it could just still be membranous. There are many other target antigens, as we know now, for membranous nephropathy, but that's also in the consideration. So again, looking at this low power view of the core, we can see that there's probably a little bit of chronic injury, which is right underneath the capsule. So a little bit of subcapsular scarring. This is where most of the sclerotic glomeruli were. So really nice looking parenchyma. So let's take a look at a little higher power. So let's see, can I clear the annotations? Oops, let's go back. Okay, thank you. Thank you, Kate. So here are some a little higher power views, so you can see the glomeruli and the surrounding tubules as well. So we'll start on this left side over here. You can see here this round structure is the glomerulus, and you can see all the tubules are more or less back to back. There are some which have a little bit of a thickening of the basement membrane, maybe starting to undergo a little bit of atrophy with a little expansion of the interstitium between them. But by and large, pretty well preserved parenchyma. The tubules really don't show very prominent acute injury changes. So this goes again with the preserved serum creatinine. So here we have a higher power view of the two glomeruli. Pretty much all the glomeruli in the sample look like this. And so based on what we're seeing now, how does that change or maybe alter or reinforce the potential diagnoses you were thinking about. You can put it in the chat if you don't, or if you don't want to figure out the annotations as well. Okay, so when I looked at this, I was like, well, maybe it could be minimal change disease. I had that same pre-test probability of the common causes of nephrotic syndrome in these patients, and so looking at these glomeruli, they pretty much look normal. So, as our first biopsy conference of the academic year, this is a fairly normal looking glomerulus. And so just to orient you again, here is kind of the hilum, the kind of the stalk of the glomerulus. Here's an arteriole, one of the arterioles that it's feeding into the glomerulus. And this is a Jones stain section where the black material is the silver that deposits into basement membrane material and into matrix, such as the mesangial matrix over here. So these glomeruli have nice patent capillary loops. You can see these round structures over here. You can see the basement membranes that are outlined by the black Jones silver stain. This gives us orientation so that the cells on the outer aspect of the capillary loop in this space, which is Bowman space, are going to be podocytes. The cells on the inner aspect, the nuclei here are most likely going to be endothelial cells, or perhaps inflammatory cells that are circulating through. And then tucked into the mesangial matrix in the center are going to be the mesangial cells and their nuclei as well. So all this to say that these glomeruli look pretty normal. One pertinent negative, if I'm telling you that all the glomeruli looked like this, other than the one or two that were completely sclerosed, is that I didn't see segmental sclerosis or FSGS. And we had a good sample, almost 30 glomeruli. So we're fairly confident that we're ruling out FSGS as a cause for the patient's nephrotic syndrome. So, so after this, we decided to go and do immunofluorescence. And so let's see what that looked like. And so this is what it showed. And so here I'm showing you the pattern of staining for IgG in all three of these panels. And so here we have a glomerulus, which is showing a positive staining. And the pattern is granular. So if you look along the glomerular capillary wall, you can see little granules of positive staining, which is the bright green staining. There are other areas that appear to be somewhat negative. The more central mesangial areas are relatively spared, as far as we can tell with this. And so we were seeing granular peripheral capillary wall staining for IgG. It was about 3 to 4 plus intensity. There was a little less staining for IgA, about 1 to 2 plus, and trace staining for IgM. Interestingly, there was also a little bit of staining for C3 and more prominently for C1q. So not quite full house, but a little bit more than we might want to see for a typical just straight up PLA2R positive primary membranous nephropathy. So this pattern of peripheral capillary wall staining with granular deposits was highly suggestive of membranous nephropathy. And even though we think of this, testing wise, for the fellows, that you should see spikes on the light microscopy slides. In very early stages of membranous nephropathy, where the deposits are just sitting on the basement membrane without a significant basement membrane reaction, you may not see any spike formation by light microscopy. So this would be consistent with kind of an early stage of membranous nephropathy without significant basement membrane alterations. But there were some unusual features. In addition to the kind of quasi full house staining pattern, we were also seeing immune deposits outside of the glomeruli. So we were seeing focal staining along these structures, which are vessels. So here's a small artery, and also focally along some tubular basement membranes as well. It doesn't project super well, but this is again kind of granular staining in some of the tubular basement membranes, but not all of them. Okay. So we have definitely an immune complex deposition process. Fits kind of the pattern of membranous nephropathy with some kind of atypical features with extraglomerular deposits, a sort of full house immune pattern. So this raised consideration, could this be something like an autoimmune or lupus-like membranous nephropathy or a secondary form of membranous nephropathy? There's also the question about whether, there's a little bit of, punctate staining over the cell bodies of the podocytes. And so the question, could this also be something like minimal change disease associated with anti-nephrin antibodies? It was way brighter than I've typically seen for the anti-nephrin associated minimal change disease. And we also had bona fide capillary wall deposits as well. But again, as we keep thinking about these entities, it's something to keep in mind of whether some of these deposits may also be internalizing into the podocyte cytoplasm. Okay, so let's go ahead. And so we'll spend a minute or two here and give everyone a chance. So I mentioned by immunofluorescence that there were immune deposits. Here we have two capillary loops. Why don't you go ahead and see if you can drop an annotation or two on some of the immune deposits that you see. And if someone's already picked out your immune deposit, find another one. See if we can get them all. Right. Very good. Okay. So everyone's kind of getting the right idea. So where would the location of of these? We use several terms in our pathology reports for the localization of the immune deposits. And so here we can see that we are looking at a glomerular capillary wall. And this is the basement membrane of the capillary wall. And then from this, we have to gain our orientation. So the outer aspect is going to be the podocytes, and the inner aspect is going to be the endothelium. Sometimes it can be a little hard to tell what's up or down. You can use other landmarks. Sometimes you'll see the shadow of a red blood cell or a lymphocyte or leukocyte in the lumen of the capillary loop. Sometimes you can see differences in kind of this granular material like serum proteins between inside and outside. But also you can look for the fenestrae of the endothelial cells, which is what these little reticulated patterns. And so remember that the glomerular endothelial cell is very flat, but it's not a complete occlusion, but it has little holes within it that allow fluid and small molecules to pass through, but prevent cells from going through as well. So this is the endothelial surface, and these are the podocytes. So automatically we can see that we have deposits which are sitting right under the glomerular podocytes. The podocytes, instead of having their nice sawtooth pattern of foot processes, are kind of flattened and condensed over the capillary basement membrane overlying these podocytes. So we have subepithelial immune deposits with essentially diffuse effacement of podocyte foot processes, and perhaps even a little bit of microvillus transformation. You can see these little spaghetti noodle-like things are little villus projections that are coming from the apical surface of the podocyte cytoplasm. Another feature you can sometimes see with diffuse foot process effacement is this extra electron density, which represents a condensation of the actin cytoskeleton as part of the effacement process. So very good. Everyone caught pretty much all the immune deposits. Very good. So these are subepithelial deposits. And another point I want to say is that you can see that there's really not a lot of basement membrane reaction around them. So let's take a look at this blue arrow deposit over here. Whoever got this was a great example. So you can see that this is the basement membrane and basically has a flat bottom to this immune deposit. So these immune deposits are basically just sitting on top of the basement membrane without the basement membrane really cupping or reacting to this. And this is why we were not seeing very many changes by light microscopy. And that's consistent with a very early stage of membranous nephropathy. Okay. So as a part of our usual workup for this, thank you, Kate, we do reflex staining to understand what the antigenic basis for this would be. So we've had PLA2R by immunofluorescence for quite a while. And even though the PLA2R serum study was negative, sometimes the tissue can be positive, preceding positivity in the serum. And the concordance is not absolute, even though it is pretty good. So we still do it even if the serum study is negative. In this case, the PLA2R was a negative study because we should have expected to see a similar capillary wall granular staining pattern, but we did not see that. We're just seeing a little bit of autofluorescence in the nuclei over here. So the PLA2R is negative in the immune deposits, and it kind of matches the serum study for this as well. So in the last year, we've also onboarded the NEL1 study because this is the second most frequent membranous antigen, maybe about 5 to 8% of cases. And so I'll start on the right. This is a case, not this one, which was positive for NEL1. And again, you can see the outlining of these granular capillary wall deposits along the capillary walls, in addition to some podocyte cell body staining, which is the internal positive control. But in our case, we only had the podocyte cell body staining without capillary wall staining, unlike this case. So this was interpreted as a negative NEL1 study. So far we have membranous nephropathy, and it's negative for both PLA2R and NEL1, the two most common membranous antigens. And so we decided to do an additional characterization for this. So this is our final diagnosis here. So we also noted that there was a kind of focal tubular basement membrane and vascular staining as well. And so we sent this to Mayo Clinic because they have onboarded a mass spectrometry-based antigenic characterization for the known membranous antigens, about 10 or 12 of them now. And this identified a peptide profile that was consistent with FAT1 associated membranous nephropathy. And so I'll talk a little bit more about this entity, which has been associated with transplantation-associated membranous nephropathy, which is a very, very rare, only maybe less than 1% of all the membranous cases that we would see. So let me first start with this study, which described this, and this is again from the Mayo Clinic, where they were looking at hematopoietic stem cell transplant patients. So exactly this patient's scenario. And so they've really run this cohort over multiple times where they had about 250 patients over about a 20-year span who were all PLA2R negative. And then they evaluated them by mass spectrometry to kind of identify additional membranous antigens in these patients, and then see if there was some clinical characteristics that would be associated with them as well. So in this cohort of about 250 patients, they identified FAT1 positivity in about 9 patients. So this translates to about a 3.5% positivity rate in the negative PLA2R negative cases. So this is really a vanishingly small proportion of overall membranous nephropathy cases. Interestingly, all 9 of these patients had received a hematopoietic stem cell transplant. And so using this discovery cohort, they went to their friends at Cedars-Sinai and asked for patients who had had hematopoietic stem cell transplant and presented with membranous nephropathy. When they tested those 5 patients, they found that all 5 of those also had FAT1 as the antigen, a membranous antigen as well. So this was kind of a nice confirmation. This was kind of a somewhat semi-unbiased detection of the antigen. And this was kind of a confirmation in a pre-selected group of patients, stem cell transplant patients who presented with membranous nephropathy. And so then they turned this through their standard approach, where they kind of verified that this is actually an antibody reacting against FAT1 antigen. So they did this a couple of ways. They took the kidney biopsies, they eluted the IgG from there, and then they tested whether that eluted IgG could recognize recombinant FAT1 by immunoblotting, and it could. They also looked at the IgG from the serum from those patients, and again, it could recognize FAT1 antigen by immunoblotting. So again, that's saying that there's a circulating antibody in these patients, and that antibody is actually present in the kidney biopsies to associate with the FAT1 antigen, which was detected by mass spectrometry. So they also found that IgG4 was kind of the dominant subtype for these, which is actually similar to PLA2R as well, which is interesting because in the mass spectrometry, they actually found all 4 IgG subtypes being present in terms of their proteolytic fragments. Now, clinically, these patients were about 60-ish plus minus 8 years of age, so very similar to our patient over here. And the membranous nephropathy occurred about 2.5 years on average after the transplant, plus minus about 1 year. I think the quickest onset that they had for the patient was about 1.5 years. So our patient presenting about 1 to 1.5 years is maybe on the shorter end of that spectrum, but completely in line with, somewhat subacute onset after the stem cell transplant. The outcome was kind of variable. Some of these patients had partial response after treatment, and they tried a whole bunch of different treatments, including rituximab. Others had progressive disease, so it was kind of a mixed bag in terms of how their membranous nephropathy responded to treatment. So this was kind of the initial presentation saying that, FAT1 could be this antigen that is associated with these stem cell transplant patients, who can present with membranous nephropathy. Now, there was a second study which showed now kind of the opposite kind of scenario. So again, now when we think about stem cell transplants, this is in terms of the patient, this is their own native organ, but they have a foreign immune system. And so this, again, there's a mismatch and a recognition by the foreign immune system of the host's own native organ to cause the membranous nephropathy. So here now in this study, they flip the scenario, and here now we have the host's own immune system, but they're receiving a foreign organ, in this case, a kidney allograft. And in that same scenario, they were able to detect FAT1 as being the antigen if those patients develop membranous nephropathy. So again, these are the same authors coming from Mayo Clinic. Interestingly, they mentioned the same 250 patients, and but they didn't talk about these patients in that previous paper. So they somehow found two other patients. Maybe they classified these as de novo membranous because they were allograft patients. But in either case, they found that these patients also had FAT1 positivity, and they were associated also with antibody-mediated rejection. Now, I want to say that this is a very small number of cases, and so they make a point in this paper that this is associated with ABMR. But in reality, and they were basing this on the fact that, they had 5 cases of de novo membranous nephropathy in these kidney allograft patients who also had ABMR. In those, they found 2 cases of FAT1 membranous nephropathy. And then they had another 11 cases of de novo membranous nephropathy without ABMR, and no known antigen that they wanted to reveal at least were identified. So this is, only 2 out of 5 cases. So, I think we should take it with a grain of salt in terms of the association with ABMR. But again, they used the same toolkit that they had before. They were eluting it, the IgG. They took the serum from the patients. They did the immunoblotting. They again saw that it's IgG4 positivity as well. So all the similar kind of clinical, the biochemical characteristics of the antigen-antibody interaction. Again, with the caveat that this is a very small cohort where they actually looked at a total of 4 patients from the multi-center validation cohort. These patients had kind of somewhat of a more delayed onset of presentation and kind of a bad outcome in terms of their kidney survival. But again, with the big asterisk that this is a very small study. So in the multi-center validation cohort, they had another 16 patients who developed membranous nephropathy without a prior diagnosis of membranous prior to allograft placement. And of those, again, only 2 out of 16 showed positivity. And again, so this is really a pretty small fraction of cases. So let's just talk briefly about um, oh, and Ashley is mentioning also that in the chat that anti-FAT1 antibodies are also often allomantibodies, and whether this can be a polymorphic gene. Yeah, this is a very good question. I was curious about that too. I wasn't able to find a clear answer to that, but I'll present to you, another idea as to why this might be a neoantigen in this kind of immune altered state of these transplant patients. So let's first talk about FAT1. So this is a very large protein, 500 plus kilodaltons. It's a single pass, so it's got one transmembrane portion. The majority of the protein is actually extracellular, it has multiple cadherin family repeats. And so it's an integral component of the slit diaphragm in podocytes. So here's kind of a schematic of podocyte foot processes. And of course, the slit diaphragm is this very specialized protein complex that interacts between adjacent foot processes, prevents them from actually touching each other, and gives kind of both mechanical and sensory feedback to the podocytes to regulate filtration across the barrier. So, of course, we know about nephrin and Neph1 and Neph2, which are the predominant components of this. But there are other components as well, like peak adherence. And here's FAT1 and FAT2, a related molecule. So these are thought to be long, kind of serpentine molecules that kind of bridge the slit diaphragm complex and are important. So studies were done where FAT1 was deleted globally, and it's not only expressed in the kidney, it's expressed at other epithelial sites and some neural sites. And so these mice, they're not embryonic lethal, but many of them die shortly after birth. They have kidney failure, nephrotic syndrome, but they can also have with variable penetration, neural tube defect, muscular body wall defects as well. And so this is really not compatible with life with the global knockout. And so groups also then made the podocyte-specific knockout. And then they found that even though they had kind of normal renal histology, apparently by light microscopy, the transmission EM showed that instead of having the normal architecture of the slit diaphragm, they had kind of an immature looking slit diaphragm where the cell-cell junctions between podocytes still remained at the kind of tight junction phase, which is this dense line that you're seeing. And this is kind of this is a normal progression of slit diaphragm maturation during kidney development, where they start with tight junctions and progress to these slit diaphragms, but they were kind of arrested at this stage. And as a result, these podocyte-specific knockouts develop massive proteinuria and nephrotic syndrome, as can be seen by the albumin in the urine. Okay? So the question is, why is this antigenic in these immune-altered states? And so it is known that the extracellular portion of FAT1 can actually undergo proteolytic processing, for example, in melanoma cells. This furin protease, which is a Golgi or ER express protease, can actually cleave the extracellular portion. And normally this is presented as a heterodimer on the cell surface. But in the case of an altered cleavage site in melanoma cells, this other portion may be secreted, exposing perhaps a face of FAT1 that is not normally exposed. And so this is again saying that under cases of immune altered states like allotransplantation, some of these antigens may be recognized as foreign and cause a membranous like nephropathy. Okay. I'll
Thank you,
hand it over
Ram,
to
for that.
Bilal as well to
Yeah,
summarize with a
thank you
follow-up.
for that extensive coverage. Now, I guess I know way more about FAT1 than I did before. So, again, there was this hesitancy from the hematology group because of the level of immunosuppression, but I told them that, this is very active disease, so I need to treat him. So we eventually started him on tacrolimus in July. They continued ruxolitinib. They were on a downward taper of his prednisone, and I continued with my conservative management of controlling his other blood pressure and volume status, and he did improve. He shed a lot of fluid weight. Blood pressures were kind of modest. Hemoglobin A1C shot up a bit. Then he did require some insulin for a while he was on prednisone. But his click one more. So this is his latest. So over the last 2 months or so, he's improved further. His proteinuria is now down to 1.8 grams on the last check. His albumin is much more stable. And from a clinical perspective, yes, he seems to be in less volume overload now, although he's still on the regimen that I've listed above. So I plan to continue for now. And thankfully, his latest PET CT also continued to show a good remission of his disease.
Thank you, Bilal. Any quick questions before we hand it over to Anand for the second case? Oh, yes, Johan.
Can I just ask a question? Partly to Bilal and maybe also partly to you. So, Bilal, you were saying at the beginning you were giving patients empirically rituximab. Like, were you addressing the same issue? And, why did you have success then? Whereas this patient, it seems like tacrolimus is the more successful regimen. And I suppose the question to you and Ram is this a form of graft versus host disease? Like you have the well, like the bone marrow producing antibody against the host?
Yeah, it's supposed to be now considered as a graft versus host disease. In fact, as a chronic graft versus host disease, if you look at that extensive 12 system table that NIH has created for grading and scoring of chronic GVHD, there is like little tiny box right toward the end which says nephrotic syndrome. So it is considered to be part of the chronic GVHD complex affecting the kidneys. And so from that perspective, yes. So based on about a dozen or so patients that I have treated, simply ramping up immunosuppression, of course, is the answer, and it helps. So and I've gone both ways. In this person, there was this concern from the primary team. I would have just put him on tacrolimus to begin with. But there was concern by hemonc about giving him that together with ruxolitinib and long term and all that. And then at that point, they also thought that there's maybe some relapse of his lymphoma, so maybe rituximab might help in that perspective as well. So those were the two factors that came into my consideration here. But over the years, yes, I've had success with both just by giving rituximab versus just ramping up immunosuppression, which is mostly based on CNIs. This is I think my 12th patient, and up until now, everybody has responded very nicely, gone to complete remission, and stayed in that remission. Yeah.
So just one final note before we hand it over to Bilal, so this time is short too. These immune altered states are very interesting, right? And it's like, why would, FAT1 be a particular antigen here? But I mean, others can be as well. We know, for example, an immune checkpoint inhibitor related kidney injury. Occasionally, those patients can also get minimal change disease like syndromes or membranous nephropathy. Even sometimes with tubular basement membrane deposits where FAT1 is also expressed a little bit. And so I wonder if some of those patients are also having a FAT1 type of membranous nephropathy as well. So let's perhaps switch it over to Anand here for the second case.
All right. Thank you. Are you able to stop sharing? Thanks. Okay. So here we are. We'll go to our second case, and for the case I'm showing, we have Dr. Beng Zhang as the clinical discussant. So Beng, I'll hand it over to you to present the history for our second case.
Sounds good. I am not Sarah Hager as listed on the screen. So we have a case in which a 35-year-old woman without really any known past medical history who was presented to the UW-ER for an elevated creatinine of 2.8. Prior to presentation, she'd been having about 3 weeks of nausea, fatigue, and abdominal pain. She actually went to an outside hospital. They noted her elevated creatinine, gave her a liter of fluids, and at the time, BMP was pretty normal. Her UA had 2+ blood and 600 milligrams per deciliter of protein, and she was sent out for follow-up with her PCP. They repeated labs. Creatinine was a little bit higher. They e-consulted UW, and UW recommended she come in for an expedited workup. So just a little bit more additional history. She had had a couple of episodes of nausea and vomiting in the week prior to presentation. Also had this weird epigastric pain that wasn't really associated or alleviated by anything. She had poor PO intake and had been taking Pedialyte for hydration. Didn't really have any dizziness, headaches, but review of systems was otherwise pretty negative and no weird exogenous medication or supplement use. This is the rest of her history. It's pretty non-contributory, past medical history-wise, surgery-wise. She's taken some supplements, Zofran and Zoloft, and no illicit substance use, no family history of kidney disease. Her ethnicity is African American. And When she initially presented objective data-wise, she was mildly hypertensive, 130s over 90s, but the rest of her vitals are unremarkable, and her exam is really benign without any abnormal findings. These were her labs when she presented. So her creatinine was 0.66 in 2022. We didn't really have any interval labs, but on presentation, it was 2.81. The rest of her BMP was pretty unremarkable. CBC was pretty unremarkable as well, but her UA demonstrated 3+ protein, 2+ blood, and UPCR was at 21.8 grams per gram, with her UACR being about 12,000. Serum albumin was 2.1, and the rest of her LFTs were pretty unremarkable. We did some additional serologic workup, which you can see here. It was essentially negative. We didn't have any obvious findings for causes of her kidney disease. We did do a renal ultrasound as well. Her kidneys she wasn't a particularly tall person, so these kidney sizes around 13 to 14 were a bit enlarged, as demonstrated by the impression. There was increased echogenicity and no hydronephrosis. And sort of given all of these things that were going on, her creatinine kept climbing. She did ultimately have a kidney biopsy.
All right, thank you, Bang. So let's take a look at this biopsy. Here is the sample at low power. We have one nice sized core of renal cortex. And the sample includes 22 glomeruli, and none of them are globally sclerosed. So in the previous biopsy, Ram helped us orient ourselves when we're looking at a biopsy. So this is all cortex. There's renal capsule and some perinephric fat over here on the left side of the core. And on the right side, there's a large artery that's about the right size and location for an arcuate artery. So the medulla would be right on the other end of that artery. And at low power, it's helpful to get a sense of how much chronic injury there is in this kidney, especially because we didn't have a clear idea of the patient's baseline renal function. So I'm showing you first a few areas where the cortex is well preserved. This is what I look for normal cortex. These tubules are nice and pink, and they're back to back. So there isn't much fibrosis or inflammation separating the tubules. And I'll note that most of the tubules in this cortex don't look normal. They don't look like that, but there's actually only focal tubular atrophy and interstitial fibrosis. So here we have a tubule that's shrunken or shriveled up, and it has a thickened basement membrane. There's a little more space between this tubule and the adjacent tubules. So a little bit of tubular atrophy and interstitial fibrosis, and some other tubular abnormalities. We're seeing a lot of pink material and white space that I'll discuss later on in this biopsy. But we'll start by looking closer at the glomeruli. I've included a normal glomerulus for comparison from a different patient in this upper left. So as Ram described in the previous case, we're looking for open capillary loops. There should be a flat endothelial cells layer on the inside of the capillaries, podocytes on the outside of the basement membrane, and then a layer of parietal epithelium lining Bowman's capsule. So in the interest of time, I might skip ahead and having you all annotate, but you'll note that most, if not all, of these other glomeruli that I'm showing from this case look abnormal. And in particular, what we're seeing is really prominent cellularity here in the urinary space between the basement membranes and Bowman's capsule. All right, so I guess we can spend a minute or two if you want to tell me how you would classify this glomerular lesion here. And you can just put an annotation on whichever lesion you think it is. All right, so we have some votes for a cellular crescent and at least one vote for a collapsing FSGS, a few votes now for collapsing FSGS. So as I'll discuss in a minute, the reason I include these options is that it's often quite hard to distinguish between these lesions. But this particular lesion is a collapsing lesion, and I'll describe in a minute why I think it's a collapsing lesion and not a crescent. So the characteristics we look for to call a lesion a collapsing lesion. First, as the name implies, there's collapse of the capillary loops or implosion. And what's important to distinguish this from other forms of FSGS is that we're not seeing an increase in the matrix or hyaline material obliterating this capillary loop. So in other forms of FSGS, there's material within the loop that's occluding it. And in this case, there's not really anything there. It's just imploding or collapsing. And then the other feature that's more easy to recognize is the prominent reactive epithelial cells. So they're increased in both number and in size. And these cells will often have cytoplasmic droplets, which are not as obvious in this particular example. All right, so as I mentioned, and as you all found, it can be quite hard to distinguish between a collapsing lesion and a crescent. So this left image is another one of the collapsing lesions, and on the right is a cellular crescent from a different case. And I think in this case, I think most of us would, at least most of us pathologists with some experience, would be confident that this is a cellular crescent. But if you only had this lesion on the left, you'd be pretty hard pressed to say with confidence whether it's a collapsing lesion or a crescent. So in some instances, there are a few clues to help us distinguish these. One of the clues that I find most helpful when it works out is that in collapsing glomerulopathy, the increased cells are really surrounding the glomerular tuft. And so if you get lucky, you'll see the cells surrounding the tuft, and then you'll see space between the cellular proliferation and the parietal epithelium. Whereas in a crescent, the cellular proliferation often abuts Bowman's capsule here. And then what it also helps to remember that the physiology of a cellular crescent, this is the result of a destruction of the glomerular capillary wall. And so in some instances, you'll get lucky again and see the actual break in the basement membrane, such as over here and here. And then as a result of the break in the basement membrane, there will be accumulation of fibrin. And if it's a particularly destructive lesion, there might also be destruction in Bowman's capsule. So these are two instances where we have some features to tell apart the collapsing lesion on the left and the crescent on the right. But there are some instances where we can't tell, and we make our best guess based off of the context, or we might defer to the clinician to decide how to classify the lesion. So in this case, we again had about 22 glomeruli, and about half of them had prominent cellularity. Not all of these lesions had what I could definitively call a collapse of the glomerular tuft, but given the context of at least some clear-cut collapsing lesions, I concluded that probably most of these glomeruli with prominent cellularity have collapsing lesions, even if I didn't capture the actual collapse in the section. All right, so the glomeruli, of course, are the focus for this biopsy for a patient with heavy proteinuria, but we'll also look at the other structures, the tubules, interstitium, and vessels. So as I pointed out at low power, there were some areas where the tubules and interstitium looked close to normal. This is not exactly normal. There's a little bit of fibrosis and inflammation between these tubules. But again, what I'm looking forward to for normal tubules is that there's a lot of pink cytoplasm for these proximal tubules, and the tubules are close to back to back. It was a focus where there's some tubular atrophy and interstitial fibrosis, a nonspecific sign of chronic injury. In many of the tubules, what we could see at low power was increased white space, which is the result of flattening or attenuation of the tubular epithelium here. So this is a sign of acute tubular injury or necrosis. And then there were some tubules where they actually looked more pink than normal, and we're seeing at higher magnification that there's this proteinaceous pink material that's filling in the tubules. The tubular epithelium is flat in these tubules, and these tubules also look a little bit dilated. Not the most obvious dilation in this case if you compare the next door normal tubule, but this is an appearance that suggests microcystic change. So I'll skip ahead the question here, but these tubular microcysts are sometimes associated with ApoL1 risk variants, as someone has already annotated. And so in particular for this patient who has collapsing glomerulopathy and tubular microcysts. Both of these findings are can be associated with high-risk APOL1 variants. I'll just briefly point out this vessel here. Important for us to not forget to look at the vessels. In this case, we're seeing a little bit of intimal thickening. So this is moderate arteriosclerosis, and not much else going on in the vessels. Immunofluorescence was negative, no immune complex deposition. And by electron microscopy, not much to see except that there's extensive podocyte foot process effacement, which is what we usually see in collapsing glomerulopathy. So here's the basement membrane. There's the endothelial cells on the inside, and these podocytes, we're not seeing any foot process preservation, and instead there's just a kind of solid sheet of cytoplasm covering the basement membrane. So to summarize the histologic findings or the pathologic findings, we found FSGS, the collapsing subtype, which is the main finding or diagnosis here. And then in addition to that, there's some tubular injury and some mild chronic injury and the tubular microcystic change. So the combination of the collapsing FSGS and the microcystic change is suspicious for a high-risk APOL1 genotype. Especially given how widespread the lesions are, we're really suspicious that this is not just because of genetics alone, and there's probably an additional trigger to result in these collapsing lesions. So we recommend looking for potential triggers, which would include viral infections, high interferon states, and other causes. So we're close to 9:30, so I'll just really briefly point out that patients with high-risk APOL1 genotype can develop collapsing glomerulopathy, but actually the lifetime risk is not that high with APOL1 alone. And we think that the high-risk genotype alone is probably not enough to cause collapsing glomerulopathy, and that it's triggered by a second hit. And these are a few of many examples, including some work from my colleagues here who have found that patients who have collapsing glomerulopathy triggered by viral infections or other conditions often have high-risk APOL1 genotypes. So I will hand it over to Bing to tell us what happened next with this patient.
So thank you so much for that. So after we got the preliminary biopsy, she was started on pulse dose steroids and eventually transitioned to PO steroids. Fortunately, you could see here on the creatinine graph, her kidney function actually made a really good recovery from the peak of about 4.5 all the way down to close to 1. And at an outpatient nephrology follow-up, her UPCR had also downtrended to 5.4 grams per gram from 22. We did an extensive viral workup and everything was negative except after she discharged, we found that her parvovirus B19 PCR was positive, which was likely the trigger of her collapsing FSGS. And additionally, we had her get genetic testing after discharge, and she was positive for the APOL1 variants risk alleles.
All right, thank you very much, Bing. We're right around just past 9:30, so I will stop there. If there's any last comments or questions before we close. All right, well, thank you all very much. And yeah, we'll be back for another kidney biopsy conference coming up pretty soon. I think just a couple weeks for the next one. So thanks and see you all soon.